Welcome to Perceptions of Substance Use with Older Adults. This training is brought to you by the Northeast Caribbean Addiction Technology Transfer Center. I'm your presenter for the next little while that we're together. My name is Diane Padilla. And so the logistics is what we get out of the way kind of now, so you don't have to be worried about this later. You will receive a certificate of completion contingent upon a couple of factors. One of them is that you have to be present for the entire session. We always encourage you, and my colleague Tree, who's hosting today, we always email you and remind you to be present or as much as possible. That is one of another many ways that we make sure that you're present, because in order to give you the continuing education credits, we have a certain amount of responsibility that the state requires us to kind of meet with them. And so at the end of the session, after you've been present, hopefully you participate. You're not forced to, but at the end of the presentation, you will be able to get an evaluation. QR code will be included in the slides. We will put it in the chat box as a link, which is probably the easiest way to really just click on it and be able to take maybe 90 seconds to submit that. That is another part of how we know that you're here, and also justifies us sending you the certificate. This webinar is good for 2 hours of KSAC, CPP, and CPS credentialing. And if you're here from outside of the state of New York, you will probably be able to enjoy some reciprocity that seems to be present throughout most of the states. So just letting you know, this is acknowledgement that this is provided by the Addiction Technology Transfer Center Network. It's our responsibility as the Northeast Caribbean, as the recipient of that grant for the Northeast Caribbean ATTC, to ensure that we provide you with the current information available. And we are funded by SAMHSA. And so we're here to provide you workforce support. This is the team that I am fortunate enough to be a part of. Patricia Chappell is my colleague who always takes care of all the logistics. She's the person to look out for in terms of your emails. She sends you the reminders, she sends you certificates, she'll even send you a copy of the handouts. Many of these handouts that I tend to use to present with have resources cited that are really instrumental in improving your information regarding the topic or the subject matter. And so I encourage you to refer to the slides whenever you need to, particularly when you're working with this community. Mr. Clive Frederick is not here today, but he is traditionally, he's our technologist. And so, oh, she put it out today. And so he's typically the silent partner that I have here. Tree's being kind enough to step in for him. My name is Diane Padilla. I am a research project manager here. I'm also the technical assistance and implementation specialist for ESPERT, screening, brief intervention, referral treatment. So when we think about substance use, when we think about how we interact with communities, when we think about the different supports, not just referral to potential treatment, but other recovery and prevention supports, I tend to do a lot of work around that. And what some of it may come up as we move along. So I have a question to ask you, and I'm going to stop the share for a second. And so one of the things that I do with almost every single webinar that I present with has to do with substance use. And just about all of them intersect: substance use, mental health, cultural issues, disparities, social determinants of health. It's very, very difficult to focus on just one thing, because most human beings are impacted by a variety of things. And so in terms of going forward with this content, I'd like to ask you all how you define substance use. What's your idea of substance use? So I didn't go over the logistics in terms of the chat. You can use your chat box, you can raise your electronic hand, and we can go from there. There you go, consumption of a chemical. Okay, illicit use, the use of illicit harmful substances. Okay, needs to be qualified and quantified. Drug addiction, use of mood-altering substances and continuum of use. Negative consequences, loss of control, and cravings. Okay. That's very good. Thank you. Thanks for starting us off. I really appreciate that. Utilizing substances for different purposes. So now we are, with prescribed OTCs, yeah. Substance use in any use. Okay, this is really, really good. Now let's start to kind of put this in a way where we are going to, where we can base the rest of the content on the concepts of substance use. Yeah, this is all great. Can no longer function. Okay. So let me just build on all the comments, all these great comments that you folks gave. So I want you to tell us, to share with the group or share or raise your hand. What are your thoughts around this comment? There's no difference between the term substance use and substance abuse. Is that true or false? A or B? What is your idea behind that? What is your thought process? Be false, okay? Can anyone speak to why that would be false?
I can.
Sure, go ahead.
Um, um, Substance use is any use, and that could be just experimentation, or it could be medical use that's prescribed. But then abuse is when you start to see those consequences, loss of control, and cravings when you're not able to have the substance.
Okay, okay. Anyone else wants to add to that?
I mean, in terms of substances, we can be talking about something as basic as caffeine. You use a cup of coffee in the morning to wake yourself up a little bit. So that's, and then, you have like psychotropic medications. That's just utilizing substances to, benefit your quality of life, anything like that. Substance abuse is more when it veers into causing detrimental mental, emotional, physical effects.
Okay. Anyone else? Thank you. Thanks, Erin. Angela, go ahead.
So to me, you can use substance, say wine, right? Have a glass of wine with dinner once a week. That's use. If I'm drinking a bottle of wine every day, that could be abuse. And I bring that up because I was recently at the doctor's with my mom. And when he went down his little checklist, he's like, do you use alcohol? And she said yes. So it was like he just checked it off. And I had to like back him up to be a little bit more clear with that. Because yes, she uses alcohol. She has a glass of wine once a month. It's not like she's drinking a bottle. And I insisted that he include that in her record because, our records follow us.
Mm-hmm. Actually, and that would make a big difference in terms of the kind of supporting care that and maybe medications that he might recommend for her, depending on her medical issues or her mental status. So that's a good point. Thank you, Angela. And we're going to talk a little bit more about that. All right, so some folks have been here with me in trainings before, and some of this may be familiar to you. The reason I ask about substance use is because the field is very focused on certain terminologies and certain understanding of the terminologies. I think that the descriptions or the definitions I heard today is more positive than what I typically hear. And what I mean is in terms of how it's been defined over time. Anyone who has been here for any length of times has seen a difference in certain terminologies. And so the answer would be, I'm going to bring this up. The answer would be false. This is the thing, and the reason I'm asking about it, it's not so much about the science behind it, but actually about the terminology. And so how we probably need to be more, aware of what the Diagnostic Statistical Manual 5th edition has defined substance use or substance use disorder as. And so for many years, we've been trained to say substance abuse. And so referring to a person, but what's been happening in terms of the terminology, what we've seen over the last few decades is that when someone is referred to as abusing a substance or a substance abuser, instead of someone with a substance use disorder, it tends to have a very pejorative perspective in terms of the person who's using, as if there was a choice where someone who is a substance abuser is often judged as willfully using substances or willfully using drugs. And a lot of times it's associated with these negative stereotypical visions or that the community or society has, presented so many times. And sometimes even though we've been working in the field for a while, substance abuse used to have a specific definition. The DSM-5 came out in 2013. That's when that version was released. At that point, the experts got together and saw how much stigma was a barrier to accessing care for many, many people who would benefit from care, for many, many people who do meet the criteria of a substance use disorder. And so what they noticed is that stigma is also reflected in language and terminology. So they changed substance abuse and substance dependence the previous versions of the DSM, and they updated it to a substance use disorder. And so I want to give you some definitions to help kind of align or realign our perspective just for the sake of this particular content. And then you can see for yourself how you can apply it in your world. And it's not so much how we define it. We tend to understand the dynamics and the neurological functions and how those are rewired and how that works for someone who may who would benefit or has a substance use disorder criteria diagnosis. But the terminology itself is associated with other things that actually influences our perception. And so here we talk about language matters. We do this all the time. SANSA requires that we put this, and I put this even on things that I do in other presentations where I'm not required to put this on. And I use it anyway because language is such an important factor. It's not just for the communities that we're serving, but also for us. How we what we understand tends to be reflective of language, and language can further reinforce what we understand. So language matters. The reason why it's here is because the stigma is recognized as to regarding why people don't access care for the most part. Stigma tends to be one of the 3 most commonly identified factors. And so here, as the ATTC, as the Northeast Caribbean ATTC, we do support affirming language and understanding how certain terminology can be very impactful with the individuals that we provide services to. So being sure that we use like recovery-oriented language as opposed to language or word or terminology that is associated with stigma is a way to help promote not just the best practices, but to help the individual kind of feel that we are certainly aligning ourselves with them, that we're trying to be supportive. And so for that reason, I offer you this before we delve into the content. So substance use terms and levels of use. Instead of substance abuse, this is what I'm going to encourage you, and this is according to the DSM-5. And so substance use refers to the consumption of psychoactive substances, just like many of you say. And it's not necessarily illicit substances. We're talking the illegal or illegality of it is not really is not a reference. It's really just the psychoactive properties within that substance. And so whether it's alcohol, tobacco, illicit substances, or street drugs and prescription medications, they all fall under that category. The other term, which you will become familiar by the end of this presentation, is substance misuse. It's the inappropriate use of prescribed, legal, or other substances. So here, you know what falls under here, under this umbrella, under this kind of umbrella term, is binge drinking, taking meds other than prescribed. This substance misuse is very specific to the inappropriate consumption, or not the inappropriate, because that's a judgmental term. It's more about the unhealthy consumptions of a substance that has a psychoactive property and the potential impact that it can have on an individual. The next one is very similar to the misuse term there. It comes from the National Institute on Alcohol Abuse and Alcoholism. And that's all terminology, just the acronym itself. Risky substance use. And this refers, and this starts to give us start to expand our perspective on how we understand substance use and its potential impact. And so risky substance use refers to consuming at levels that results in harmful or hazardous consequences. And harmful is a person indulging, whether it's alcohol or prescription medications, not taking them as prescribed, or whatever they're using, they're consuming in such a way that can put them at risk of having a health issue. Or it can exacerbate existing mental health issues like a depression or anxiety. So it doesn't mean that they meet the criteria of substance use disorder. So that's why someone is harmful when they are at risk of developing consequences or experiencing consequences due to that risky level of consumption. Now, those that are consuming at a hazardous levels are folks who are indulging and are experiencing some of those consequences. And even like that, they still don't meet the criteria of substance use disorder. And so this is the opportunity to kind of widen our spectrum, our perspective about substance use, because the substance use disorder has to meet a certain criteria in order for it to be a diagnosable condition. And so all these terms are different frameworks that refer to levels of consumption not just the amount of consumption, but the levels of consumption and the risk and the impact that it can have on an individual. So building on this, we're gonna move forward and start to understand and think about how medications, work, the benefits and the downsides of medications for older adults. And so this is in the slide. This is something I'm going to encourage you all to really refer to when you get a copy of these slides. Any comments, any questions about this? The reason we're trying to do I just want to be clear that the reason we're trying to do away with substance abuse is because when a client or a patient can hear it, it can be very debilitating, emotionally, psychologically, and can really minimize their ability to understand that there is, that they may be consuming at levels that puts them at risk. It almost seems to show, or it almost seems to reflect that an individual is doing something on purpose, even if they have no control. So we want to bring the science and the basic understandings that we have to the terminology, because what we say is going to impact that individual. And it's not so much our intentions, because our motivations and our intentions are not measurable, but our words are impactful, and that has an impact, and that is measurable for a particular patient or client. And so that's why we're trying to move away from that. And because we want to try to minimize stigma even in our language. And so it's just a matter of just evolving. And so benefits of medications for older adults. So there's some things about medication. When we think about perceptions of substance use with older adults, we think with older adults, we tend to think of the medications that they do take, that they tend to take. And so this community has certain medications that are more commonly prescribed to them, perhaps more often than other age groups. And so vaccines help prevent many infectious diseases. So we know that anyone, and we're going to speak to an older adult as someone who is 55 or older. And so we'll borrow the age frame for now. Not all the experts do not agree when it's when it's a person, an older adult, when a person can be referred to as senior citizen. But for our purposes, and for the understanding of the content, we're going with people 55 and older. And so one of the things that do happen with folks who get older over time, your PCP or your primary care provider or Department of Health sends out PDSAs or sends out notifications to remind folks, especially the folks in older communities, about the availability and accessibility to the flu shot or the pneumonia shot. The pneumonia shot tends to be recommended along with the flu shot for folks who are over 55. Most people are reminded about the flu shot, but not necessarily the pneumonia. And that's typically saved for older folks or folks with certain conditions. And then we also see the medications, the benefits, including antibiotics. We all know that antibiotics can help someone, including pneumonia. Bacterial-based, infections can be fought off with antibiotics. So we know that these medications can be helpful, and particularly within specific scenarios, specific realities with the folks in our client community that are older. We see that it may look very specific in their world. Drugs to control high blood pressure. So we know that it helps prevent strokes and heart attacks. There's populations that we work with, and they have a tendency to have diabetes or high blood sugar levels are controlled by insulin or other medications. And so it really helps to kind of stabilize an individual to give a decent quality of life. It can reduce the risk of eye infection, which is also the certain vulnerabilities of eye care, of eye complications when someone has diabetes. And so these medications help to control all of this. And so drugs to control other pain issues. There are folks who have chronic pain as a result of certain health conditions that they have. And so the medications can help all that. The other thing about medications is that many times as providers of the workforce, tends to look at, when we think about perceptions, the reason the title is perceptions and not just bias is because we have all kinds of perceptions that has to do with substance use and the communities we work with. So there are some biased perceptions of substance misuse, particularly when it goes to, when it's regarding the older adult community. So alcohol and substance use and substance use disorder often go underreported. For those folks who actually can meet the criteria of substance use disorder, it's undertreated because it's not necessarily detected. It's not detected because most times it's not screened for. And one of the things, so I do a lot of, some of you folks may have gone to my expert trainings, there's a really encourage and emphasize standard or universal screening for everyone, not for certain communities and certain, and omitting some other communities, just doing it as a standard of care. And that way you don't miss anyone. And so the idea here is that when some settings do not screen the older communities, it could be, and this is nothing is templated here, but it could be, I don't like absolute statements. It can be that perhaps we are not seeing this older community as a community that we may have to have a challenge around substance use problems related to this community. With this community, with older folks, we tend to think about age-related issues. And so substance use in older adults don't necessarily connect. And so oftentimes, if we don't do that, that might be informing our policies or our protocols where we're not screening folks, everyone, and then we're missing some of the older folks that may have a substance use problem. It doesn't even have to be a substance use disorder. It can be just a level of consumption that is unhealthy for them. But if we're not screening, we're not finding anything or having any reason to explore and have a conversation with the folks. So sometimes the stigma in a stereotypical perspective includes of ageism, which is that failure to think that an older person may have a problem with substance use. So there's a study that SAMHSA did, one of many. You see this the source cited at the bottom, and I thought it was interesting to be able to capture some of the anecdotal comments that were included. You know, there was providers. One individual had said, treatment wouldn't help anybody at that age, and so I'm not sure where that's coming from. There was no explanation for what the thinking was, but that is some of the attitudes that was identified, was captured, within the survey that was taken. And so sometimes my client doesn't seem to meet the criteria of substance use disorder. That's not necessarily untrue. And so we can talk about that because the way the DSM-5 developed the criteria for the different conditions that is used to diagnose a particular maybe problematic health condition for an individual, we're done mostly with adults, not necessarily with older adults. With adults usually under 55, where the biological makeup or the biological functions are working in a certain way, very different from most times from most older adults. And so that may not be such a far-fetched comment. So biased perceptions of older adults in SU also include societal norms. Societal norms tend to reinforce that the perception that older adults don't have SUDs. We sometimes have these ideas that older adults are, have lived their life, which is great, and they've worked hard, and hopefully they're enjoying their, their time right now. But we don't necessarily have the very visuals. They're not part of what often is a stereotypical visual that society has tended to present time and time again. And older adults are not included in there, whether it's a biased one or any kind of one that shows older adults might be having a substance use problem. So, and then another thing that happens is that the community themselves, very often, what happens with a person is as they get older, they may not necessarily be aware of how the changes in their body, the changes in their mindset, how that can affect how they process medication or substance intake. And many times, many people don't understand what substance misuse is to begin with. So it's kind of hard to understand if you don't have, if you're not aware, you haven't been formally educated on physiological changes as the person gets older, the age-related issues that come up. And then they don't even know what substance misuse is, and how in the world are they going to be able to identify that? So that's an opportunity that we have as providers to be able to disseminate some of that with them. So the inability for them to discern the difference between substance misuse and similar symptoms of physical and cognitive decline, is pretty common in older adults populations. Many times, even in other age groups, many times what the substance that someone might be consuming or indulging in can provide symptoms that may mimic other healthy conditions or mental health conditions. And so we'll talk a little bit about that. So sometimes those symptoms can be misinterpreted. So aging is associated with degeneration-related physical pain. And so there are, like, I'm thinking of a colleague of mine who, well, she's retired now, but she lives with fibromyalgia. And so that is chronic pain. And she does her darndest to kind of navigate and juggle the different opportunities without using a psychoactive substance to mitigate that. And she does exercise and different things. But folks who get older tend to have some of these chronic issues. And so there's some of these issues that might incur medications that like these opioid analgesics. And so that just having the accessibility can also increase the risk of substance misuse. And so risky substance use can be similar to different symptoms. So that's one thing I just mentioned in the other slide. Consider, like, for instance, when someone has, if someone has gastric issues, sometimes somebody will go into urgent care and they have gastric issues, and they may have, say they have a diagnosis that they've been living with for any number of years of, say, IBS, irritable bowel syndrome, something like that, or some other gastric related condition. And so some of the symptoms that happens there can be very similar, whether it's the constipation or extreme diarrhea. Some of those and the aches and pains that can happen and around the stomach area, all of those are also reflective of very similar symptoms of taking some alcohol and other substances. They can provide the same symptoms. The only way to discern would be to do an actual screening. And again, it brings us back to that point. If screening is not being done and we're not asking those questions, it doesn't even have to be a whole formal 410 questionnaire. But if we ask questions about the alcohol very specifically, Angela mentioned about a simple question about, does a person drink alcohol? That's not telling. It's more about asking, have you had 4 more drinks in the last 30 days or in the last year? How often has that happened? So there are very specific questionings that a person can elicit responses to be able to discern between symptoms. But sometimes when the focus is that just on the health issue, then we may focus just on that and not think that substance use might potentially play a part in a particular condition that an individual has. So it's really important to understand how some of this can be confusing, can better inform the kind of supports we can give the client community. Any comments, any questions so far? Anything that kind of seems weird? Okay, in that case, can I get a volunteer to read the next slide? Or I can volunteer you. I can pick on you. Tama Lani. Oh, we got Carissa. Carissa, thank you. I'm going to put the slide up. If you can read it as close to how you think it was written, I'd appreciate it. Thank you. Go ahead, please.
I'll be 68 in March. I've had beer or 2 every night since I was in the mid-30s. Never had a problem until a few months ago. Lately, when I was drinking my beer, I feel a little tipsy. My son says I'm slurring my words. What's going on?
Thank you. So I'm going to get away from here for a minute. And I'm going to ask you folks. What do you think that's about? Or there's no right or wrong here. Just what does that seem to speak to?
Possibly she's mixing alcohol with her prescription drugs or some other drug.
Okay.
Just not putting the two together.
Okay.
She could be drinking more than what she is reporting also.
She could. How about we pretend she's being accurate? Let's work from that perspective. What might come up for you if you actually, with her, her confusion or his confusion or their confusion?
Could be decreased liver function, making the alcohol not be filtered as quickly.
Okay, yeah, that's a good comment. That's good.
Good morning. So similar to what the participant just said, that there could be some medical issues going on where due to possibly the immune system in the elderly that starts to diminish. And so the 2 beers that the person may have been drinking when they were in their 30s and 40s and early 50s may now be having a different effect on the person as a result of the immune system overall in the body starting to decline or diminish. And so that person may need to have a medical workup, or if they just want to be more reactive to what's immediately going on, they would want to experiment by cutting down on the beer to see if that effect remains of slurring words, or if it gets better if it cuts down from 2 beers to one. So if I was speaking to the person, I would sort of explore those areas with the person. If I was not a clinician, but rather like a son or a relative.
All right, thank you, Oscar. I want to, and that just brings up a point for me. So thank you for that very comprehensive response. I want to make a point for this. This can be helpful not just for clinicians, but even for non-clinical folks, as educators, as support staff, even as peers, peer professionals. This information is really about helping us understand what are some of the dynamics happening in the community, how we can better support them. Doctors will have a much, much deeper, more clinical perspective, which we'll speak to a little bit in terms of medication dosing. So thank you for that. Virginia, I saw your hand up.
Can you hear me?
Yes, I can. Hi.
Hi, everybody. I think the gentleman who was just speaking was right on it. I don't know the proper medical term, but I would look at it as sort of a reverse tolerance that starts to happen to people as they age, where substances begin to hit them more strongly. Even things like caffeine can become create the same effect. They may be more jittery with a half a cup of coffee when they used to drink 3 cups and things like that.
Mhm.
I've experienced myself. I turned 67 this month. I haven't had any substance, drugs or alcohol substances, and I've seen this happen. I'm saying it very inarticulately, but grandma who used to drink 3 glasses of wine is now slurring or tipsy with a half a glass of wine and things like that. And nothing, medications or not, I think it can just happen as we age. We don't process it as well physically.
Yeah, no, you're spot on. All of you are really speaking really well to this. And I see the chat box is actually speaking to some of the things that you just brought up to Virginia. So you mentioned, Angela mentioned reverse tolerance. There was, so there's some suggestions about requesting that they see the PCP for physical to ensure that there's not anything else going on. Could be completely unrelated. If the condition gets worse, maybe then also think about, when they also just so happen to drink their beer, it can get worse. Decline, I like when Stephen would include here, the decline in liver function. All the functions change. So I know we're all spring chickens here. So what I'm going to do is I'm going to go over some of the things that happen naturally. One of the reasons why I thought 55 is the appropriate age to really to refer the content to is because that's when physical changes start to happen. So I want to bring, so those are great comments. And all you folks are really spot on. What I want to make one mention before I go into some of the general things that we see in individuals who start to age up. So is that this person is not aware of the changes in their body, of their changes. They're not doing anything different that they haven't done for a long time. One of the things that I think, you can tell me about if I'm wrong, but I think most of us can relate to being conditioned to doing things in the way it has always worked for us. And so what happens physically in terms of medications, in terms of how food works and what it looks like on our body, especially when the fat increases, boy, having some information about or some understanding about what happens with our bodies physically can better inform what we can do about it. And from that perspective is what we can support our client community to understand so they can make better informed decisions. What happens is that a lot of times those changes, those physiological changes, even the cognitive changes is not necessarily information that is given directly to the individual. And so maybe a person might get, okay, a certain recommended dosage with a particular medication for a particular issue, but do they get all the other aligning support information that is specific to their livelihood and for them to understand this is what's going on, this is why you're getting the medication, this is what you want to look for. So that's interesting. It's that the community themselves are not always aware about what's going on in their bodies and how their changes, how their body is changing. And so this individual is like, okay, they're wondering like, what's going on? I've never had a problem with this before. All of a sudden I'm slurring my speech. And so that brings us to pharmacokinetics. So pharmacokinetics tend to be, it's an understanding of how physiological changes happen in an individual as they're aging, in terms of how drugs are processed in the body, how it's absorbed, how it's metabolized, and so on. And so some of the very basic aspects that are age degeneration and age-related include the increase in body fat. So when body fat increases as a person gets older, there's less muscle mass. And so that affects medications, not only as their immediate impact, but there is like a wider distribution of medications throughout. So it's a slower process to target the area they're supposed to target. And it may last, and it can also last longer in the individual's body. And so fat increases and mass decreases. And so it can be noted a lot of times the changes in a person where they may sleep longer. Okay. Sometimes because they're sleeping meds, tranquilizers may need to be adjusted because as a person getting older, they tend to sleep longer. Or sometimes their sleeping patterns are disrupted. So it's also the body water tends to decrease. And so naturally women are cisgender females, able-bodied females, average person, tends to have less water content in their body than cisgender males. And when a person is older, actually that decreases that much more. One of the things about substances is that substances also need, these different things that happen simultaneously, by the way. Substances also need water for distribution, for metabolizing. And so when someone is having a drink, now remember this individual who doesn't understand why 2 drinks all of a sudden having such an impact on slurred speech and them feeling tipsy. Alcohol needs water to metabolize in the body system. And so a person, instead of maybe just 1 hour to process a standard drink, an older person may need much more time to process that alcohol, that 1 drink, because there's less water in their system. Other things that are going on, the gastrointestinal processes tend to slow down. So the gastric digestion, how someone what a person ingests and how they process and metabolize and break that down, the absorption, how that is distributed throughout the body functions are slowing down. So the distribution process is slowing down. The emptying, the excretion of unuseful matter, all of that is slowed down. And so if that's happening, that may also have an impact on whatever alcohol consumption or whatever medications a person is taking. Albumin, levels of albumin are also decreased. And this is often associated with the liver and the pancreas. It transports substances throughout the bloodstream, but it decreases also the metabolism of the medications. It's a much slower process. So as people age and the kidneys are less able to excrete substances, the decrease of the liver function was addressed and was spoken to in the chat box as well. You picked up on that. When those processes, those biological process functions are slowing down, so chemicals can accumulate in the body. What happens also is that the process of metabolization, oh, there goes a tongue twister for me. It slows down in the liver, and particularly with certain substances that are very harsh. Alcohol is a harsh substance to process. Some medications are harsh substances to process. And so it takes longer. And so when we start to think about why there are certain doses of certain medications with certain timelines with folks, and with some food with food and some without food, has to do with how it correlates with the aging body. And so, and these doses for the same medical condition or with the same medication that's recommended will probably look different on someone who's less younger than 55, because the metabolism or the biological functions there are not necessarily as slowed down as an older person. And so when all of this starts to come together, it's a really good opportunity to help share it with the community. There's some medications and alcohol that are slower to be excreted, remaining longer in the body. So also think about that little case study where Carissa had just read out for us, where the individual was having 2 drinks, and that 2 drinks actually may have seemed to have an impact as if they had like maybe 3 or 4 drinks. And it stays in the body longer, so the impact will stay longer. It may take longer to impact, but then the impact can actually be longer in a lengthier time. And so the increased sensitivity to alcohol, also increases the risk, for instance, for alcohol poisoning, something that maybe somebody never had to think about before. Then that's a consideration. Impaired vision, the vulnerability in the eye condition or the eye health, the vision health, it also plays a part in how the liver and the kidney are working together and how they process and metabolize alcohol and other medications. And so the slow reaction and the increased chances of falling, the equilibrium is challenged. So we start to understand why some of these things actually do happen with some older folks. And so substance use in the aging community. Let me just look at the chat box. Is there any questions that you wanted to ask here? Natural changes in the brain functions is the slower response to decreasing memory. Thank you. We're all in this together. Very good. So 25% of older adults. This is where our concerns start to come in. 25% of the older adults use prescription psychoactive medications, and the accessibility to these substances on their own already increases the risk of misuse. And so concerns regarding misuse of medications along the combination of alcohol and medication misuse has been estimated to affect about 19% of older Americans. So I'd like to ask you all a question. I want you to kind of fill in the blank. Almost 90% of older adults regularly take at least 1 prescription medication. Almost 80% regularly take at least 2 prescription medications. What percentage of older adults regularly take at least 5 different prescription medications? And you can put your response in the chat box. I see that folks are going towards the higher end. Okay. All right, thanks everyone, I appreciate that. Not too far off. So the last time I looked, it was a certain amount. It was 36%. And so 36% of older adults take at least 5 prescription medications. Now I want to share with you, we currently have about, from the 335 plus million people population in this country, 62 million people are considered older adults.
Wow.
Now that's the highest, that's the biggest amount that we've ever identified in the history of this country. Mm-hmm. And so it's really interesting because there's also projected that there will be unlikely like 30 million more within the next 10 years predicted. This is just what research data kind of tends to suggest. And many times, they underreport really. So they miss the mark because they aim too low. So this can be very modest. So the idea here is more than 90% of people who have 1 prescription medications, we're talking about, the different health-related issues and maybe other conditions that could be genetically inherited, or they can be other, environmentally induced conditions. But the thing is that 90% of our older adults have one prescription medication at least, and a predominant amount of these folks have two. The fact that there are folks who are taking 5 prescription medications, may be really considering that, maybe something to consider when we think about how medication adherence is such an important factor to living a healthy quality of life, an important factor in somebody's wellness process. There was this one survey that they followed 17,000 Medicare recipients. This was done by the Center for Medicare and Medicaid Services. And they had 17,000 Medicare recipients. And what they did, they followed these folks over a period of time. They found that 2 out of 5 patients reported taking 5 or more prescription medications. What was interesting is that almost 55% were non-adherent. Another concern, and this is why this is called perception of substance use, because being able to elicit this information, to be able to screen, to be able to help folks make informed decisions about how they're using the medication they're prescribed and other potential psychoactive substances can be very helpful for that. And so prescription medications misuse. One study of over 3,000 adults up to the age of 85 showed common mixing of prescription medications. And so that includes, and somebody had mentioned about over-the-counter drugs. So non-prescription substances, dietary supplements, many times folks will try to supplement or augment an effect of a medication with an over-the-counter medication, or maybe an affordable over-the-counter, medication. So patients that were over the age of 50 were noticed to have 25% who have misused prescription opioids or benzodiazepine express suicidal ideation. And so these are other things that we want to be mindful of, that the risk is not just prescription substance misuse, that there may be an issue of substance use disorder, is that it can impact in other ways as well. It can certainly exacerbate depression or anxiety. It can certainly increase the suicidal ideation and potentially attempts. It can increase isolation from depression, which is a barrier to care, to support. So we can think about how this can potentially have different outcomes. There was chronic conditions, health conditions are just part of an aging process. The concern comes a lot with, is really about not having not just how the medication is used, but all the other health-related information that can help an individual see the realities of their life so they can manage their medication use or their consumption of alcohol or other substances in a healthy way. And that's something that doesn't necessarily get across to the folks. And so, let me see, I have this note here. There was a particular study had from 1999 to 2019, Americans 55 or older died from an opioid overdose, and that's pre-pandemic, and that's when the current wave that we're still in of the opioid overdose, this current wave. We have also the high, I don't know what the numbers, I don't remember the numbers right now, but we have the highest amount of older folks who have also succumbed to overdoses. And so the risk of having so many medications, the opportunities to help them adhere and manage their medication use and potentially other issues that can exacerbate the medication use is really urgent. It's more urgent than we tend to understand. And so having folks who, like almost 80,000 folks who have died from an overdose, that's at that time. And the numbers are just as prominent today with the current in the last few years. And so I thought this was great. Among 50 to 80-year-olds, there were adults that drank alcohol. 1 in 4 reported having 6 or more drinks at least in one occasion in the past year. Does anybody remember, can anybody remember what, or know what the recommended drinking guidelines are? What are the recommended drinking guidelines according to the National Institute on Alcohol Abuse and Alcoholism? This is for anybody.
Yeah.
Go ahead, Lindsay.
I think it's one, is it one drink of alcohol, 0.6 ounces of pure alcohol per hour, to 0.6 ounces of alcohol per day, and no more than 3, never more than 3.
Okay, and that's pretty perfect for cisgender females. So they used to say no more than 3 in a day for a female. Of course, also including at least an hour to process a drink, because it takes at least an hour to metabolize that ethanol for a standard drink. So thanks for mentioning the 0.6 ounces. So if somebody's having, or right now they frame it as 1 per day for females,
Right.
not to exceed
No more
7 in
than
a week.
5.
And no more than 2 per day for cisgender males, not to exceed 14 in a week. Those recommendations were initially developed for people who were under 55. New York State OASIS and other entities, and even when I do my expert trainings and I do the alcohol-related stuff, and I use the NIH references as well, we tend to use, for no more than 1 drink in a day, not to exceed 7 in a week, for cisgender females and persons over 65. Because biologically, those functions have slowed down. Virginia, I see your hand up. Please share with us.
Oh. Sorry. I was just going to answer the question,
Okay.
which you already did.
Yeah.
So
But Lindsay did.
yeah, Lindsay did. Thank you, Lindsay.
So it's interesting because this is okay. So this is I made a big deal about this a couple of days ago. So when you have a box of cigarettes, I used to smoke. Some people who never smoke, great, your lungs are fantastic, I hope. I used to smoke. And so I remember that, and I believe it still has it, that a cigarette box has that little square Surgeon General message. The one that you need 3 pairs of glasses to read, that one.
Yeah.
So that tells you just a little bit, that has to tell you that, you got to kind of consider what you're doing here. Kind of. I don't think it helps, but that's my bias. I'm more than happy to put it out there. Have you ever heard of, have you ever seen a bottle of vodka, a bottle of liqueur, a bottle of Chivas Regal say consuming more than 1 drink a day is considered unhealthy? The public does not necessarily know that. And that's my point. It doesn't necessarily come with that information. So in our culture, we are used to doing certain things. Hey, after you live your life and after you've worked all your life so hard to provide for your family, to do certain things, when you right now, even if you're not a person of age, of an older age, you still, a part of the culture in this country is, you work hard during the week. So in the weekend, you can have a couple of drinks, it kind of, you can relax a little bit. It's part of socializing, it can be it's part of our nature. So that thinking, that conditioning is part of what people still do when they get older, unless they have some information to help themselves to kind of tweak as they go along to help improve and update their information so they can make better decisions and that relate to their health issues. Someone can be somebody who's going to have the most fabulous quality of life, but it really helps to have the information. So if your culture has part of your culture is these habits, and I'm not thinking of culture of race and ethnicity, culture in terms of patterns and behavior, in terms of values and things that you're used to doing most of your life, or you adhere to. And from that cultural perspective, if this is part of what you're used to doing and you don't have any reason to change that, why would you? So you may have some health issues. The provider might see that there's some health issues going on with you, give you some recommendations for medications. And if you don't screen or find out if alcohol or other substances have something to do with it, and especially today, because marijuana now is legal, for a lot of medicinal reasons. So we have other players in the field. So if that's the case, if we don't have the information, how can that older person be proactive in their own wellness process? And that's the whole point of this. And so it encourages us to look at substance use differently than what we may have been traditionally taught. It also encourages to look at it from the lens of the older person, and also helps us to understand how they correlate with degenerational issues and perhaps some other psychosocial factors from their environment. And so let me go back to here. Okay, so one of the things, so among those who drank, they reported drinking while using other substances. So 67% drank alcohol. That's fine. But 20% drank more than 4 times a week, 4 times per week. It was the most natural thing in the world. And you know, it doesn't, there's no reason, you know, maybe they have some medical issues, but nobody's thinking that it has anything to do with the consumption, the alcohol consumption. They're going to continue to do the same thing. So 27% of folks had at least 6 drinks or more on any one occasion. And so on the right-hand side, what I want to include also is, you know, there's the smaller percentage that was identified, and this is from 2022. A smaller percentage of older adults were identified with having difficulty with their memory. And so some of them might consider it a blackout. Some of them may think, well, their memory is going because they're getting older, so the memory is somewhat compromised. You know, the cognitive decline that can happen. And so maybe not necessarily think about the potential impact of alcohol consumption, especially if they're only having 1 drink on an occasion, and how that may have had an impact on the days that they're having the memory challenges. So 1 in 10 adults say they drank while using other substances like the marijuana, the prescription with tranquilizers to help people go to sleep. Prescription pain pills, not just the list of substances. I mean, we do have issues. There are folks who are using substances to actually get the high. There's a lot of folks who are trying to use these different psychoactive medications to help themselves to live as normal of a life they can on a daily basis. And so when we think about things like that, is that the perspective of the client is also important. So remembering that the drinking guidelines are for one drink per day. So this is what I just went over. And so, and this is also something that I've included in the expert trainings, as the audit is an alcohol screening instrument. Tend to recommend that any agency and every agency, when most times we folks have intake processes, those protocols, that paperwork that folks have to provide responses for while they're being admitted, not just to your program, I'm not thinking about the treatment programs, I'm thinking about the other health-related programs, preventions, recovery supports, you know, other housing and health issues that can be covered under particular programs. You know, a lot of times what you have is an intake process. Many times the intake process has 1 or 2 questions regarding alcohol consumption. The unfortunate part is many times those questions are asked that you can have put a response to it, or however the person, whatever the person indicates, and you document that, but then there's no scoring or interpretation. The screening tool is designed to be able to identify if there's a potential issue that needs to be explored. But if you're asking the questions and there's no score and an interpretation of the score, then why ask the questions? So it's kind of like what Angela was saying. So you drink, okay, I'm going to document that you drink. You're not really doing anything because it's not informing anything if just because a person drinks, because you don't know how much, you don't know what they drink, and you don't know how often. And so that is all really important information, because with drinking, let's just say that when it comes to alcohol consumption, if you have a screening question, you have the opportunity that if someone is scores at a moderate or risky level, you can have a simple conversation with them and perhaps intervene. And then you can continue with the rest of the intake process. So there are opportunities, and I'll be discussing that later. So when is moderate drinking still too much? And I get excited because this information is so relevant and so many of us don't have it. So when we're talking about the older population, taking medications that interact with alcohol, that is sometimes moderate drinking is just too much. So even if somebody is drinking 1 drink a day, maybe that 1 drink might be too much if they're taking other medications. Just because they took the medication early in the morning and they're driving in the afternoon does not necessarily mean they're safe to do so. And so that's a conversation for the physician, for you to have with that individual. And And so an individual who is taking any kind of medication, no alcohol should never be mixed up with any medication to begin with. If a person has an alcohol use disorder, of course they're not supposed to. The choice is really up to the person. But what we want to encourage is the recovery process, if that has been helping them. Usually people who are recovering from AUD don't have the ability to stop drinking, so they don't drink. Or they shouldn't. That wouldn't be the healthiest thing. It's really about how you're going to approach the subject and address it with them. So when somebody's planning to drive a car, participate in other activities, requiring alertness and skill, that's especially important. So alcohol and other substances can have an impact on how your body works, in your motor skills, in your cognitive skills. If someone is going to an event with family and friends, if maybe it's not driving, maybe it's a matter of certain things they're going to engage in. Maybe they're going to do, let's say this, many times what I've seen a lot of folks do, they get into the walks. They do walks for a particular cause, cancer walks and other diabetes walks. And so, and which is wonderful. And physical activity is always recommended for the older adult. But if you have a drink earlier, or you take another substance earlier, and you think 3 hours later you can do this, it might impact your ability to actually participate. And so things like that are the things that come to mind. So it's really a matter of starting to understand, starting to understand how in a particular person's world, their specific world, how their level of consumption or their level of indulgence, their adherence or non-adherence to medications, how that might be impacting their lifestyle, and how you can better inform. So the effects of substance use. I said, also be aware to not focus on the 7 drinks a week. We can recommend saving on medication. I would say don't even focus on the one a week or the one a day, because one a day sounds minimal. It really is about not just about how you frame it, but how it looks like in their world. If there are other things, if they have health conditions that have debilitated, somebody who has to walk with a walker, and they want to engage in certain events, or there are certain things that they need to do on a daily basis. These other, even one drink, even half a drink may be too much. And so it's really about understanding how to tailor this very specifically for folks. So conditions that working with alcohol use. So we know the stroke can get worse with it. The risk of stroke can get really worse with someone. High blood pressure can be exacerbated. Let me see here. Okay. All right. Okay. So high blood pressure, diabetes, ulcers, osteoporosis. We already know the memory loss is part of cognitive decline, but alcohol can certainly exacerbate that. Any kind of mood disorders can be exacerbated by alcohol consumption. Even when drink, it really depends on the person and their current level of what condition they're at. There are many people who in older age, not just because of age degeneration issues, but because they have other illnesses that may have been genetic, or they had more likelihood, or maybe as a result of a particular, life situation, folks have higher risks of some of these. And so these other substances and medications usually take this into account. That's why doctors are always asking, what other medications does a person take? What are the other conditions that they've been diagnosed for? What are the surgical procedures they may have had? It starts to give them a glimpse of or just an idea of part of the history of the individual as they get those biomarkers in place, as they start to understand some of the current issues that they have. This is all part of how they make recommendations. Well, that's why I'm always stressing about the alcohol consumption. And these days, not just alcohol consumption, asking about marijuana, because for folks with debilitating eye vision, it may be impactful. So we have to understand how these other substances may be playing a part in their world. But it can certainly exacerbate a lot of these issues. So the dangers of mixing medications and alcohol, say if you take aspirin or drink, your risk of stomach or intestinal bleeding increases. And so when you think about maybe how many times an individual may have gone into urgent care with gastric issues, with extreme gastric issues and pain, and maybe they have felt that they ate something that didn't agree with them. And if the facility, whether they are coming to you or they're going to I don't know, a healthcare center or an urgent care, you know, if they're going, they have stomach issues and they're not being asked about any kind of alcohol or other medication intake, and then that's not being assessed or scored and interpreted, then we lose the opportunity to identify mitigating factors, factors that we can mitigate better. And so the stomach issues may not necessarily be because of this chronic gastric condition that they have been diagnosed with years ago. It may have something to do with something else. And so, but we won't know unless we screen for it. So when you combine alcohol and some allergy medicines and antihistamines, for instance, it can make you very sleepy. And that for older folks can be very dangerous because they stay sleeping even longer. Now think about how that might impact adherence to some medications they need to take at certain times for certain conditions. Alcohol use used with large doses of acetaminophen can cause liver damage, particularly if it's done periodically or commonly. So I have this wonderful person in my world and somebody who I have much respect and love for. And one of the things that he says is that when he takes Advils, he has to take 4 Advils. The person is well into their 60s, and when he takes Advils, and I always ask him, I didn't understand because I've seen him a couple of times do this, and I didn't understand why. And I said, you know, there's specific instructions for that. And he just said, yeah, but I have built a tolerance, so they don't really affect me if I don't take this much. I says, have you ever thought about what it would do to your stomach? Have you ever thought that maybe you're in a place right now where maybe 2 can actually be effective, but you haven't given yourself a chance to find out? One of the things I learned with him was that he didn't realize that certain issues biologically, you know, they start the slowing down of these biological functions, you know, do provide an opportunity for those that dosage instruction to actually work effectively as is, that he doesn't have to augment anything. It really speaks to how people who have been doing things for a long time a certain way continue to take that on because they've always worked. You know, why would you change it unless you're given information to break patterns and improve or update, you know, or augment your health? Some medicines such as cough syrups and laxatives have a high alcohol content. Of course, you know, we know when you mix and blend them, you know, you increase the risk of, you know, of stroke, of falls, and so much more. As chemical reactions and poisoning, alcohol poisoning and stuff. Alcohol used with sleeping pills and pain pills or antidepressant medicine can be absolutely deadly. And so some of the triggers, and so some of the things to also consider with this community. What do you think? Matter of fact, before I bring anything up, triggers that exacerbate substance use. So this is a question for y'all. Let me reframe how this is set. Think about some of the older folks that you work with. What may be some of the things that happen or some of the realities in their world that might potentially put them at risk of misusing substances? I like that, Catherine. Thank you. Grief and loss, friends and family. Think about that. And for all of us, or especially for folks who are older who have lost friends during the last 4 years from the pandemic, then having to process that, like, you know, long-term grief can be, right? So think about how that might potentially say, you know what, I want to not think right now. Maybe let me take something. And not necessarily because somebody's trying to get high. It's just like, maybe they want to break. Maybe they just kind of want to just feel okay for a little while, you know? So let me, some other comments say the loneliness, yeah. Environmental changes for sure. Trauma is so unfortunate, but trauma is always there. Okay, coping mechanisms. A lot of times people will use a substance to cope. And sometimes they use, you know, okay, let me just keep saying what you folks have. Loss of partner. It would be the same when some doctors prescribe 100 milligrams ibuprofen. Okay, extreme trauma behaviors that have past experiences. I like the financial issues, loss of vision, hearing, loss of independence. Habits that they've already had. And so when we think about some of that, we think about we think about the realities of that person's world, how they're dealing with the realities of their world. When someone gets older, you know, how much support do they still have in their life? How actively are they engaged or interacting with other support system, whether it's their family, whether it's friends, whether there is a community. Many times, being able to access services and being connected to you folks is really huge because you're a support. So that's a nice way to kind of as that's a contraindication for loneliness to a certain degree, but they can't see you every day. They can't see you all the time. So who else is in their world where they can feel supported? Let me see. Mobility issues, older we get, the more trauma we experience. Sometimes their age is not the same as their psychological age. Interesting. The way we learn to cope with emotional distress, mental health services, a lot more stigma. Yep. Death, dementia, they may not want to go to senior services. Well, you figure that adjusting to realities of folks can be an issue. I think about I do some work with some folks, and in terms of some older folks who are in long-term nursing home residential care, adjusting to a different environment, adjusting to not being home, the home you worked for all your life, not being home and having to depend on a system that is not so personal, it's not your preferred system, so you can have some kind of health and wellness in your life because you can't do it on your own, or you can't do it within your home. The adjustment just for that alone can be really, really huge and very profound for many of our older folks. You see some of the changes with retiring, and to the point that you can no longer you're not able, you don't have the capacity to actually go to continue to do the kind of work that you did, let me stop talking to you as if you were the client community. For folks who have to retire, to stop doing something it's so self-rewarding that they've been doing for a long time, that adjustment can exacerbate substance use. You all mentioned the death of a family member. It can also be a pet or close friend, and the pandemic really exacerbated those situations for the older community. Income, financial strain, and that has a lot. In the income and financial strain, I'm going to talk to you about how substance misuse can be a consequence of that. The loss of purpose. If you're no longer playing a role that you thought was really important throughout your life, that spoke to speaks to who they are, their spirit, how they've always been, and they no longer have that. The loss of purpose is part of how we define from Sam's side, the 8 dimensions of wellness. Purpose is one of those components. And so for an older person who does have felt like they lost that purpose, we could probably help if we were to augment that opportunity for them. And so, but these are, we're talking about exacerbating substance use, the things that increase the risk that can potentially have someone use a substance that maybe they have in the medicine cabinet that they still have after the last surgical procedure. That might be an opportunity to listen, I just don't want you right now. Let me go take this because I remember how I felt. So the loss of purpose can be part of it. Relocation, placement in a nursing home, trouble sleeping, family conflict, and mental and physical health decline. And all the other stuff that you folks mentioned, not being able to go outside. The mobility piece is huge. For some folks who can use a walker, just having to use a cane or having to use a walker is an adjustment in and of itself. Not being able to actually have freedom and the capacity to, on your own, to freely move around in and out of your home can be a huge adjustment. Yeah, allow them to have a say in changes they may need to make, help them to be more accepting. But yeah, it's certainly part of how we may support them. Having that support is part of what can help them and helping them see options that they may not be aware of. So examples of medication misuse also include the mixing of prescription medications. But one of the things we've also been seeing is that folks are using over-the-counter medications kind of to augment the prescription medications or kind of replace some medications that may have been recommended. And so just think about maybe someone who has maybe a budget or limited income and maybe co-payments. And I know there's some programs like program RX. I forget exactly what it is. And there's a couple other programs that are available where, you know, some folks can get supplements or helps or some medications for free. Sometimes folks will take an over-the-counter medication because they feel it's healthier than whatever perhaps psychoactive medication that they're being given for whatever health issue. But it's the mixing of these over-the-counter medications and the prescription medications that can increase their risk, you know, of impact of health issues. Mixing that with alcohol and not necessarily running it by the physician. So taking several doses, medication misuse is also taking several doses of the same medication or when not needed. So here's the thing. So if it's prescribed for a person to take it at a certain dosage at a certain time frame, so they're taking it when outside of that, or taking many more than what is offered, say because they feel like they have a high tolerance. But doing those decisions on their own and not running them by someone, that's huge. Failing to fill a prescription, and sometimes it's because they forgot. A person can forget. That's not unheard of course, with the older community because of the cognitive decline. But here's the thing: sometimes somebody may not fill a prescription not because they don't remember, but because financially they're not in the place to do it right now. So think about that. So sometimes, medication misuse also includes that. So stretching out medications can actually be a consequence of that. Sometimes, and I know some folks who I've worked with who actually do try to stretch out their medications so the refill can align with when they will get their income check when the income check comes in. And so when a person does that, and especially with certain medical conditions, even though they're stretching out their medication, they're trying to be adherent, they're trying to take it, they know they need it. But a lot of times what happens is it's not working according to what is the way it's prescribed. So, and the way the medical condition the person has needs it to be taken. And so that's misuse also. But you can see that there can be mitigating factors that affect how a person or why a person would not take it as prescribed. So it's not always just about getting high. You do have the folks that will go from one doctor to another, to try, to just maintain that level of that euphoria level to actually feel, that who may have a substance use disorder who no one has picked up on yet. But you also have a lot of folks who are trying to work and manage the details of their financial details and the financial details of their life and try to make it all work together. And so not adhering to dosage description and missing doses and double dosing can increase the risk of hospitalization. And so using medication with intent to self-harm for addictive purposes, which is what I just spoke to. The thing is, what is the support system in their world? Who are they able to actually run this by? Because if they're not running it by anybody, they're not sharing it with anybody, and this is the particular one of those recommendations that we usually encourage the older patients and older clients to, like, whatever medications they have, to make sure a family member or friend is someone close by who checks in on them every once in a while, is aware of what medications they take, what the dosage is, and so not adhering to that can put them at risk if they decide to try to kind of stretch the medications to align with when the finances come in and so on. And so asking for help is not can be a hard thing for some folks, but also knowing that there are resources out there to help folks in those situations is something that many people still don't understand or are aware of. So not taking medication as prescribed is pretty much what I was just saying. Missing the dosages can really complicate not just can complicate the medical condition of the individual. Folks with high blood pressure or diabetes who miss doses, you end up being at high risk of going to the hospital. And 25% of hospital admissions of persons 65 or over are due to inappropriate adherence of medications. And so inappropriate adherence is not just overdoing it, but is overusing it, but underusing it. So, what's interesting is that if you ask a lot of the folks, many people were taking so many medications that are prescribed for different health conditions, and they had a choice. If they had a personal choice, they would rather not take them. So this is one of the surveys that really speak to that. And I just wanted to make sure that we're informed. Our perception is informed. 80% of individuals taking medications up to 80 years old are willing to stop taking one or more medications if their healthcare provider said it was possible. So these folks are actually working with their PCP, but if they'd rather not take as many. If it was possible, they would take less. 26% has stopped taking at least one prescription medication taken for more than 1 year. This is on their own. And so this has to do with the medication. Sometimes, I remember back in the day when we were, when we stopped saying AIDS and we started to just work with HIV before the PrEP medications and these wonderful rates of underdetected individuals who have an HIV illness, when medication and rates of HIV were still very, very high. I remember thinking I remember how we had to help so many folks and how to adhere to different medications. And there was such a thing as, I forget the terminology, but it was where a person just got tired of taking so many medications with so many specific instructions. It became very taxing and took a toll on different individuals. And we see some of that happen with the older population when they have a variety of different medications to have to take, especially at different times of the day, at different timelines, with and without food and so on. Yes, Oscar.
Okay, thank you. I have known of a few senior citizens who on their own have tapered off prescription medications and have gone holistic. This is more on those persons that are diabetic or with high blood pressure, modifying their diets and so on and so forth, taking vitamins. Are there any statistics on that? People who stop taking medications on their own without a doctor approving that?
You know what I would say is, yeah, it probably is, because that's what this is based on. Let me bring this up. Was this slide? Nope, this slide. So there's some resources here. This is one, and I can give you the resource this, and I'll send this. I'll give it to Tree, who's playing host, who's being our host today. She's the one who sends you the medications. Excuse me. She's the one who sends you the PowerPoint slides and the certifications that she goes out. She sends them out. I will send this to you all so you can have the source it came from, and you will see the statistics. So that's what this is speaking to. Unfortunately, that also means that there are a lot of higher rates of complications due to medications. So what happens a lot of times is when someone does staple up on their own, if they're not sharing about, say, the challenge of having to take so many medications, and not necessarily about forgetting, it's just having to take that many medications and trying to manage that. If they're not sharing that with someone, those concerns are not known. If we don't ask about that, where we can intervene and support, then these folks are not just at high risk of hospitalization, but what can also happen is that their medical condition can exacerbate, and maybe the medications after a while may not be the same ones to take effect. That maybe something more harsh treatment recommendations may need to be recommended in order to address the complications at that level of the medical condition. And so it can really go in so many different ways. Erin, I see your hand up.
Yeah, I wanted to just comment on Oscar's with the kind of switch to holistic treatments against provider recommendations. I know that I work with schizophrenic patients in the community, and we have had a few who, they do get these delusions, paranoia about medications, and they switch entirely to holistic. So I think that that's definitely that this is a certain demographic where that is a higher risk, as people with cognitive distortions or any type of schizoaffective disorder.
Yeah, it's interesting because you were talking about schizophrenia, and I'm thinking about schizophrenia, and so thank you for adding that good point. There are some of these medications that are pretty harsh to take. Sometimes the adverse effects, for lack of other opportunities or other options rather. Some medications can be very hard for some folks to take to deal with the adverse the side effects, and sometimes some folks stop because they feel okay. And so I can just imagine how some of the folks in the older population who have to take a variety of different medications, who may try to go a holistic approach without running it by a medical practitioner, may not necessarily be as informed on how to do that and may be putting themselves at risk. And then I also know other folks who have taken the holistic approach, who have run it by not just their medical practitioner, but other specialists, to be able to see how that can be a supplement or a replacement for some of the medical treatment recommendations that they've given. It's really a case-by-case scenario. So thank you for mentioning that. So identifying and addressing substance use with older adults. And so, so there is this really, really a much more robust amount of information that has to do, that would be helpful for us to be aware of when we are supporting folks. And the more familiar we get with that, the better we are able to tailor that support according to the unique needs of any given individual. And so, and this is just some of it, just some of the more common things that we think we see that we don't necessarily recognize or can inform the community about. So I've been stressing all this time about the need for screening for substance use with older adults. So identifying and addressing substance use with older adults, it's the importance of that. It can't be more expressed in my saying by what I said earlier. We currently have 62 million folks who fall under the category of older adults, and there will be 30 more million between the next 5 to 10 years. And so 30 million more, that's a lot of folks. So we need to get a little bit more adept at what we're doing. And so this is what's going on with the older adults in our community. According to some sources, 1 out of every 4 65-year-olds today will live past age 90. So the resources are needed, the information is needed, the support is needed. 1 out of 10 will live past 95. That's a huge change from decades ago, where I think the mortality was at 75 or 78. So folks are living longer. So in 2021, there were 55.8 million adults aged 65 or older. And almost 189,000 more than in 2020. And so, and those numbers are increasing, of course. And so, and like one of the things I just want to reiterate is that, that the surveys and the studies and the statistics that we have are usually modest compared to what the actual numbers are. And up to 4 million people, our estimated number of adults in the US identify as transgender or gender diverse. And so we wanted to present and understand that there are very unique issues and unique approaches, tailored approaches that we really should be mindful of. Being culturally and linguistically appropriate, being trauma informed, because trauma is one of the things that, not just that you folks mentioned it, but having had traumatic experiences in people's life, and how adjusting to different aspects of living at an older age can be challenging for some folks. So these are different frameworks and concepts that we need to translate in practice. So nearly 10% of older adults do live in poverty. Older women are almost twice as likely to be living in poverty as older men. So racially and ethnically diverse older adults are also more likely to be poorer than the white older adults. So here's what I do with statistics. I like statistics. I like to know what the general patterns are. What I can encourage you folks to do is be aware, who's your population? Who is the community you're working with? When you're thinking about the folks who are over 55 within your client community, your client population, and who is the community, where is the community that you're working with? What are the prominent issues that seem to commonly present? And think about the diversity in terms of race, ethnicity, in terms of gender identity, in terms of economical background, in terms of age. And so understand where they're living, and then you start to understand how different factors can intersect and impact their wellness. And one of the things that other trainings we tend to go into, or I tend to go into extensively into, is the social determinants of health. And the social, and I probably should have included that here. Social determinants, when you think about, and this is something you folks can probably speak to too. Social determinants of health being the conditions where someone is living and where that impacts their wellness. And so do they have accessibility to appropriate healthcare? Do they have accessibility to, let's just say for older folks, are there community resources that are available for older communities, for older populations? You know, there's some community centers that are available for adults and youth. They're not necessarily catering to the older adults. So you have some senior citizen centers. Are those accessible? Do you have them? If you don't have them, are there other support programs that organizations or resources in the community have that they are aware of? Many times they're not. If you're living in a rural community, if that's where you're providing services, what is it that is available for the senior citizen that cannot necessarily drive out? Senior citizens or older Americans are not necessarily the most open to connecting telemedicine. So that's not necessarily the best support system. What are the other potential opportunities that you have in your community to connect them with? So everything needs to kind of be considered from their perspective. What's kind of real and what helps, what can be helpful to them from their perspective. So we would do it differently. We were working with youth. If we're working with youth, we have to tailor our services accordingly. So we wanted to do the same thing with the age-related community. And with that, with the age-related community, we're talking about access. We're talking about ramps. We're also talking about access within distance. We're talking about it's not just so easy just because someone has Medicare to just get, you know, the accessoride. I can't tell you how many times I've heard someone complain about how that system works for those who can get it. Not everybody can get it. We still do. We have a lot of situations where folks have medical conditions to the degree that they would benefit from a home health care of professional for 8 hours, and they're lucky if they can get 2 or 3. You know, it's so thinking about all these different factors very individually per person is what's going to help us best support them. All 4, yeah. And so, and I remember when my mom was sick, she really would have benefited from longer hours, and we were trying to get her overnight help because she wanted to stay home, and so she was a person that worked all her life and had her nice home. She was by herself, but that was hers. That's what she worked for. And she couldn't stay there by herself anymore. And so she needed help. So the times when I would come after work needed to be supplemented by a home health aide. She only had 4 hours. We had to work around the hours that she was alone to ensure how she can stay safe. It's a real tricky thing when it's family. So I know you folks as providers are able to kind of work and mitigate that very individually. It's very different for each person, depending on their financial status and depending on their capacities, depending what's in the community, what's available. Unfortunately, insurance has a big say-so. You know, insurance has a bigger say-so than a physician does. I'll leave that there because I have my own bias against that too. But how we can bring it all together to elevate the quality of life for any given individual, along with the information they need to make informed decisions about their medications. That's really helpful. Let me see what you folks put. So would anybody like to add to here? Because you put a lot of stuff in the chat box. Here's something I appreciate. It's horrible. It's a horrible system. Yes, it is. And yet we're the ones that we can be resourceful. We can be creative how to navigate that system for our patients and our clients. So if we can do that, we can help them understand how they can do that, at least to a certain degree. Hi, Stephen.
Hey there. I work, by the way, at agency called Argus Community in the Bronx. And actually, we are doing a whole project around engaging older adults in substance use that we got some OASIS funding for. But, you know, one of the things I've done similar trainings to what you're doing here, and yours is excellent, by the way. Thank you for sharing it. One of the issues that I like to cover with people is the whole issue about dealing with caregivers, including, you know, physicians and so forth. And there's the way stigma works with them is the level of embarrassment or reticence they feel about talking to an older person about their drinking or drug use. It's something they don't like to broach very often, and or making excuses like, well, Steve's an old guy, you know, let him have his fun, you know, he ain't gonna live much longer anyway. That's that sort of thing. The feeling like, you know, they don't want to intervene because, you know, yeah, Uncle Steve likes to snort here or there, but that snort turns into 5 or 6, and as you pointed out, you wind up falling down the stairs in the emergency room, or your diabetes or hypertension is under control. I think that's an important area for us as behavioral health people to really educate the caregivers in our communities, you know, particularly medical caregivers, about this problem, and really have them try to, you know, make more of an effort to probe this subject with their older patients.
Yeah, thank you. I think that's a great suggestion. Thank you for adding that. Awesome. Nice to see you, by the way.
Thank you.
Erin?
I know that definitely for me, something I've had to kind of work around, or like work to get more comfortable with addressing substance use with some of my older patients is just, you know, there's that ingrained, like built-in respect your elders, you know, like your elders know best, you know, learn from them, be guided by them. And then I'm showing up and I'm a 26-year-old little clinician, and I'm like, okay, let's talk about nicotine replacement therapy. And they're just like it can definitely be a barrier in, you know, not like I know better than you, but, you know, I do know that this is something harmful for you. Can we kind of collaborate on a way to treat the issue when, you know, it's a, you know, 75-year-old who fought in a war and, you know, has seen a lot in their life, and they just have someone like me showing up and, you know, not telling them what to do, but telling them that they shouldn't be doing what they're doing.
Can I just say something to that, if you don't mind? It's really owning your approach. It's really how you engage.
Yeah, I have been able to learn that, but when I first started, it definitely was difficult.
Yeah, it's how you approach. I mean, because one of the things we can do is not tell anybody anything, but share information. That's really how you frame it. So that's one of the things that can help. And there's more to it than that, because my expert stuff is coming up. I don't want to get into that. But yeah, because once they feel the comfortability with you, they know they can trust you. They know that you are a person that's giving them information, that you have their wellness at heart. And I think that's what happened with you.
Yeah. It's a lot easier 2 years after my start date, thankfully, but it was a challenge in the beginning.
Thanks. Amber?
Hi, I really am enjoying this training, because I work with the state of Florida for the opioid epidemic. And one of the things that we're seeing, I mean, obviously we have a very large population of people over 55. And one of the things that we're seeing is, you know, the lack of assessments with our medical providers. But one of the things that I love about this training is especially the very beginning, when you're talking about language, because we're still not very language forward in Florida, is what I'm finding out. But changing the way that people look at addiction or substance use, moving those words and allowing someone to think of it differently, I think is going to help, because that's one of the biggest things that I'm seeing. I have an 80-year-old mother-in-law who, every time she drinks more than she should, I'm not an alcoholic, Amber. I never said that. But you know, that's one of the things is those words are so inflammatory that it prevents people from getting the help that they need and deserve. So I appreciate this so very much today. I'm going to share this.
Great. Thank you, Amber. Hi, Lori.
Hi. I one of the things, and yes, this is a topic. I work with an older population now as well too, and I have my father was 92, passed away about 18 months ago, and my mom is 93. And I'm blessed, first off, but the challenges, the stigma of all of this prevents when someone that is elderly, that doesn't use, when they go to the doctor or the hospital, the stigma against them prevents them from really getting treatment that they need. My mother, when my father passed away, she was never alone. She had severe anxiety and freaked out so bad. I called the doctor's office 6 weeks before we could get an appointment. I took her to 3 urgent cares. We can't do anything because all I needed was something to help her with anxiety. She's not a medication person. She doesn't drink. And finally I took her to the ER. They offered admitting her, but she has no psychiatric history. She has nothing like that. She was just having a situational event. And so I finally went to the charge nurse and begged her, and she gave my mother 4, I don't know, Xanax or whatever, 4. So we left there with that. And that was 2 years ago. She still has 3 left. So the stigma of when a person doesn't use prevents them from getting the help that they need was my experience. I just wanted to share that because that didn't.
No, that's great. Lori, this is the reason why I'm always putting that same slide about how substance terms, how they're related, how they're defined, and how it doesn't necessarily have to be a substance use disorder or what we use to term as substance abuse. That people are consuming at levels that are giving them an impact. But if we were to convey the information that way and let people know, because what we know in society is that you use substances, automatically you have a problem, you need treatment. And so to kind of combat that, I try to give those terms, those definitions, because for every person who does meet the criteria of a substance use disorder, there's 4 to 6 people who are consuming at levels that's impacting their health. Because they're not taking the medication correctly, because they have to stretch it out, because they might have the 2 drinks they've always had all their life, and they don't even know that one right now may be a risk. Information that is not the normalized information that society has. Because as society, we like to stigmatize a lot of folks. We have uninformed perspectives, and unfortunately, we as people who don't work in the fields that you folks are working in, internalize those negative perspectives. They're very uninformed. So
the young woman that made a comment earlier in the presentation about when she took her mom to the doctor and he just checked off the box that she drank, and she stopped him and she said, "No, wait a minute, you need to put that in the history." That made me that's point an example.
Yeah, thank you.
Thank you.
Thanks, Lori. Hi, Virginia. What we're gonna add? You had your hand up. I don't know if it's coming down automatically.
No, I was putting it up and down as people were starting to talk. I didn't want to keep it up. I had a couple of different thoughts back when we were talking about insurance and being able to help people with staying in their homes and receiving the right kind of care and stuff. I live in Rhode Island, and I think our state is doing some stuff that other states are trying to maybe adopt more. They have some active programs to help older adults stay in their homes longer. Unfortunately, like a lot of things, this was at least in large part driven by them recognizing it saved them money. But it still makes people a lot happier. And toward that end, they're finding ways to kind of compensate caregivers who are helping, older family members and things such as that. And then not in my current job, but when I've worked in community-based substance abuse treatment, I know that Medicaid, Medicare, and private health insurances all will have abilities to help somebody go to their home if they need it briefly, if that's all they can do, to help them get set up with the whole list of community services that might be available for them for substance use or just general aging or mental health or behavioral health conditions. And the many, many grant programs that are out there that work on combinations of all of that mix. And so I don't know if it's everywhere, but a lot of the people I've worked with, Rhode Island's a tiny state. And so I've worked in DOCs and detox and long-term and short-term residential. I've worked in corrections, and now I work in a psychiatric hospital. People in this state have a very good awareness of how to avail themselves or how to help their neighbors find resources to try to maximize what they can do. I don't mean people still don't fall through the cracks and don't get all the services they need, but I guess I have this up and should have had it down. It's really heartening to see how well we do reach out to people, and big community fairs and walking events and stuff for the mental health, like this being Mental Health Awareness Day. Yesterday was mental health, or this week I think is Substance Use and Mental Health Awareness Week, and it's kind of plastered all around. And then the lists of free resources for people and service organizations and churches and other philanthropic organizations that will help. So, you know, whatever those sources are available in your own states, you know, as I think of it as part of my job to be able to know that and pass it on to people I work with. That's all.
Thank you. Can we take your suggestion? Let me just bring it to the larger group, folks. Whatever resource you know of right now, if you can type that into the chat box, that would be great. Because I'm going forward, I would take all of that and I would include it in the slides and just broadly disseminate that. So if you folks, no matter where you're at, whatever resources you're aware of, please let's help each other here, put in the chat box, and then I'll take it and I include it going forward. And that would be great. I would be very grateful for that. So I have a few minutes left and I want to go through, I really love this conversation, but I'm going to go through a couple more things. I really want to show you the screening tools. So the discerning between substance use, most older adults who misuse substances don't meet the DSM-5 criteria. And that's something I had mentioned earlier. What we can do as providers is engage older adults in management and education regarding substance misuse, health, and wellness. We can provide specific small informational seminars, or we can, when we see the individuals on their own, we can tailor certain information to their specific needs and provide them options. It's not just giving them literature, it's being able to normalize some information that is specific for that will be specific for them, and being able to provide that, providing them resources, helping them be aware of what those resources are, helping them by providing access to them. Becoming informed about age-related physiological changes is something that we can't assume that all older adults already know about. That's not necessarily the approach. And something that I think was Aaron, I'm not sure it was Aaron or Lindsay, using a person-centered approach is key here. It says a person-centered approach we use with everyone. It includes the older adults. I can't I can't approach someone to start to tell them what they need to do, what they need to know. I need to be able, and this was just spoken to, is your approach is going to really speaks to how we engage, or how we initiate a rapport, and how we engage them in a conversation from their perspective, using a person-centered approach. And there's more information and more trainings, webinars on that. So, and then one of the things that Lori kind of built upon when I first opened up about the language, you know, stigma discourages people. You don't know what folks know in the communities. So when you start engaging them in your care to provide them support, if we make a conscious decision about the words we use, we can actually minimize stigma in our wording and ensure that the transparency in terms of how we communicate with that individual about when we're talking about, you know, sometimes how medications are misused, you know, depending on the realities of their world. It's really not about pushing someone away and thinking that, well, looks here like you might have a substance use disorder, you might, you know, benefit from treatment. That's not the way to present that. It's really, what we want to do is engage that individual, because their wellness is the utmost goal for us, is to help support them in that. So we should be mindful of the language we use and kind of refrain from using stigma language. It's really more about using recovery-oriented language, understanding what the substance use perspectives are. It's not about so much about just disorders, but a lot of times it's about a misuse. And, you know, and it doesn't necessarily mean that there's a negative reason for that. There's a benefit to why folks might be using substances the way they do. Is understanding what that is and listening to that information and working with them for where they're at. And so I do a lot of SBIRT is screening, brief intervention, referral to treatment. The referral to treatment is just part of the acronym, but it's really referral for further assessment. Really what it is it's a process that helps providers understand how to intervene with an individual who might be a moderate or high risk. SBIRT, it's the only reason, it's the only goal, the main goal that SBIRT has is to intervene with someone who might be a moderate or high risk for problems related to their level of consumption, not to look for somebody with a substance use disorder. That's already taken care of. There's other approaches that work with that. If someone might have a substance use disorder, we don't know that, but the screening tool might identify someone with a high risk. But what we do is with this process, we can actually screen someone, have a conversation with them, intervene with them, and check in with them afterwards. And so it has these three components. It's a universal screening that I stress all the time. Whether you're using expert or not, screening should be standardized that way. We don't want to miss anyone. And depending on the screening score, it might warrant having an awareness building conversation, which is typically a brief intervention. And all you're doing is just increasing their awareness about potential health issues and their potential and their level of consumption and how that correlates and impacts their world. And so that's a way to intervene. And that's before anybody has an issue of substance use disorder, but it's already feeling consequences of their level of consumption. So in the referral to treatment component is for further assessment. That's another component as part of the model, because if we do find someone who can benefit, there's a way of approaching that as well. We don't tell anybody, but we do have a potential component here to be able to address that. One of the biggest things is to understand what screening tools to use. The audit is great for most populations. The DAS is great for a lot of populations. These screening tools are specific to the older population. Why? Because this includes those degenerational issues that tend to be associated with aging. And so these screening tools are specific for that. If you're using an audit with a 72-year-old, it's not conducive. It's not tailored to their specific issues. And so the SAMI tool, that's one. I also have here the short mask as a geriatric version. It also gives you an insight as to how to conduct a screen and how to score. And then it has an interpretation. It has this, if someone has a certain moderate risk, then you can have a conversation, a brief dialogue motivated by MI, very brief. It doesn't have to take more than 15 minutes. And so this is another one that is used, assist, light. It's also specific to the community. And there's an interpretation here that I want you to look at. I'm coming down on time, and I know it's a little challenging here. Just want to share with you that there's a benefit to having a dialogue, an intentional dialogue on your side that you use communication skills very strategically, where it feels like a conversation on the other side, where they feel like you're being approachable, where they feel like they're in a safe environment, where they feel like they can be candid with you, that you're really being their ally, you're being supportive. And so it's just a short conversation to increase their awareness of what their risky substance use behaviors may be. And so we have that terminology. I'm not going to tell a client, so you have some risky substance use, in your life right now, let's talk about that. That's not how I would approach it. There's more on that as I do the next aspect of brief intervention trainings. The idea is to be able to have a conversation where they can be informed, and that information raises their awareness of what the realities of their life are and how they can adapt their behavior. And so it's usually based on MI, which is a person-centered approach. And so this brief intervention is just about understanding what the risky behavior may be, respecting the choice of the individual, what they want to do. You present yourself with the spirit of MI, which is you're there with them to meet them where they're at, not where you want them to be, and use some basic communication skills to do that. And so this brings, you like the oars? Yeah, me too. The oars were just, kind of like basic 101 communication. Whether you were a clinician or not, or a health educator, everybody was trained on oars back in the day, or at least when I first got into the field. And so, but this has been an essential piece of motivational interviewing. And motivational interviewing, you don't have to be, a trainer of the year. It's just very simple skills that are focused on the person, and you work with what they tell you. It really isn't that complicated. And this is just a great way to approach folks who are older in their life, who are dealing with different challenges, and where we can support them as an ally. And so I'm going towards the last couple of minutes. And so what I'm going to do is just kind of thank you. Yes, the active listening. Or is this open-ended questions, affirmations, reflective listening, and summaries? The active listening is part of it. The MI spirit is part of it. There's different ways of doing reflections that can be key. you know, but come to another training on expert and then I'll show you a little bit more about that. At this point, what I want to do is I just want to thank you all for your participation. Thank you for staying engaged. We'll be more than happy to send you this material. Just need you to look in the chat box for the code. Here's some resources here that can be helpful, but I'm going to add the ones that you folks are adding today. So I want to thank you for your time here today. It's been great. I'm going to have another more evolved presentation on this community, kind of like a part 2 within the next few months, because they really need our help. And so I appreciate all of what you're doing, and I appreciate your time here today. Thanks, everybody.